Okay, jetzt wieder ein Talk auf Deutsch.
Now let's switch back to German. Dr. Wolfgang Müller-Felber from Munich will talk to us about the non-muscular symptoms in CNM therapy. There are patients that don't have only muscular symptoms, but other symptoms as well. Well, my part is to talk about the not so spectacular elements, but we're talking about the present day, and so there are a couple of issues to raise. There are three groups of non-neuromuscular symptoms. First of all, there are immediate consequences of the weakness of the muscle. The second group is we know that myotubularin works on very foundational principles. Myotubularin does not only affect muscles but also other parts of the body. And we have elements that have not been studied yet, combinations of myotubularin with other body parts. Well, let's focus on the first part. The immediate problems can include osteoporosis, and we will focus on the osteopenia at first. Osteopenia takes place and is an issue with every skeletal disease, osteopenia. For a long time, it has been known that children suffer from this a lot at MTM patients. There are several reasons for that. One of them is that bones not only have the function out of the form, but also the form follows the function. A bone that is not being put under stress looks differently than a bone that is used a lot. Many children have a lack of vitamin D. We know that most children play on the computer, on their Game Boy, and hardly get to experience the outside world. If a child sits in a wheelchair, then it's even more difficult for the child to get enough vitamin D. We should think about this a lot because all the rest can be difficult to mend. There can be a disbalance in the scoliosis, which means that the back can be, the back muscles, back bones are not as structured as with healthy children. We have found out that the scoliosis also has to be cured, and it is not easy to cure, because here you see the problem of thin bones. A surgeon can have difficulties to work on this. You know that many children with MTM are very skinny, where also skin problems can be an issue. A great question that we have to focus on, and I think nobody has yet come up with a great idea, is that the muscle forms the skeleton of the body. For example, with MTM, the muscles also of the tongue can do very little. That means that there can be problems intubating because the muscle is just not strong enough to cooperate. We do not know if the palate can be supported by some sort of metal assistance, but there are also problems of breathing difficulties. Do I really want to put tubes into the mouth of the child to improve its situation? I personally don't think that's very difficult to decide on that, and so are surgeons. They're also divided. Another problem is the bite and the location of the teeth. Often you can see that the parts of the tooth do not match in the way that healthy people would have their teeth matching. We often see teeth growing into random directions and a malpositioning taking place. One problem that we always have to think about is that the entire system, the entire mouth area is deformed. We also have the problem that the tube that connects the mouth and the ear does not function correctly. That means that liquids gather near the ear and that the child can hear more difficultly and that it makes it also more difficult to learn a language. We have patients that are difficult to understand because of the dysfunction in this area. A child with issues in this area cannot speak correctly, and we have to focus on what is the most important problem. With these children, we usually have to take a very precise look. Is it a dysfunction of the tube? Or why is language development impaired? Often, children will have to see the appropriate doctors to know where the development is going. How is the genetic defect connecting with other growth problems inside the body, for example, of the heart? Most things that we discuss from clinical studies has been found out by the group around Hermann in the late 90s. That was a very large group, and I think very little has been added since then. We know that the children are very tall in the beginning. You can see from this graph that the children grow faster in the beginning. We know that the age of their bones is higher on average. I can only talk about the ones that I have worked with who have lived beyond puberty. But at the end of the day, I've found that the size is not as different to that of healthy children. I don't know anybody who has gone out of an MTM with 6'7" or something. They haven't outgrown their peers. That's something we don't have to focus on. A second thing that we should discuss is, you know that many children have a problem with their scrotum. The scrotum is misplaced. We know that children that have been born early have a problem with retained testicles, and that is even more drastic in children with MTM. The decision that we have to take today is how aggressive do we work on this issue. We know that there is a high risk of testicular tumors. Our strategy has changed. Nowadays, we are more prepared to do an exploration and to change the position of the scrotum than we were in the past. Now, let's talk about the liver. I'm sure many of you have heard about these problems. It's certainly scary to some extent. We often see that the transaminases are elevated. With 2 children, we have observed a very intense icterus that had a very intense raise, with one child reaching 20-fold the norm. We also know that there is increased risk of gallstones, and another key word that always comes up is piliosis. That is a problem that I will go into for a second. I think concerning the liver, it is very important to note that, and I've experienced that myself, it has to be the greatest care must be taken when a liver biopsy is taken, because there is a very high risk that bleeding occurs. It's a very high risk of bleeding, and with these children, the indication has to be made very carefully. Of course, if there is a high-risk patient, it can be done, and our patient survived, but he had intense bleeding and was hospitalized. And one case has been published where a child has died after a liver biopsy. That means think very clearly about whether or not you would like a biopsy of the liver. The piliosis, as you can see here, is a bleeding that takes place at some parts of the liver. The arteries that pass it are opened, and when this happens, the children can actually die from internal bleeding. The parameters of the liver can be very different from one child to the other. It's hard to find out about the risk. There is a lot on the table that is being discussed, and we can always discuss about breathing assistance, etc. But I think that the risk that a child has difficulties breathing is greater than the risk that a piliosis takes place. I personally find that this question should be taken with a grain of salt. Talking about blood and the blood parameters, there are a lot of ferrocytes in the blood. Usually these ferrocytes are flat, but with MTM there are some ferrotypes, plateaus, that can lead to gallstones. If I have these round ferrotypes, then the function of the liver can be limited and ultimately lead to gallstones. That is why we constantly check for gallstones with children. We don't know, however, if there is a clear line between one and the other. There are other children who have problems with their blood coagulating because of vitamin K. We are not sure about the number of cases, which means that you don't have to check for the coagulation with children all the time, but there is a standard procedure that should be followed. I think coagulation can occasionally be carried out, but it's usually a trivial matter. Now, what concerns the heart and the functions of the heart, we know that MTM can often cause problems with the heart, but myotubular myopathy can lead to mutations like the T10 myopathy. I've never experienced one for certain, but we always look at the heart. We always try to check the heart, that it can cause stress, but if the lung is not ossified enough, then the heart rate will reduce. It is similar to when you reduce the heating in an apartment and the air pressure rises. It means that we have to definitely focus on the breathing elements. Now, a final few questions. We know that many children have a large head. We know that some who have fits. We have some that have cognitive limitations, but mostly these things are because of breathing assistance that didn't take place early enough, severe issues like that. In order to call it a brain problematic is something that is not normal. The brain is not usually touched by MTM. We see that the ventricles are very large. This is what we often see with early-born babies. A second story that has only occurred in very few cases, that bleeding can take place without symptoms being visible. So that's also not a problem. We do constant checks on the size of the head and of the brain, but there is no point bringing your child to the doctor all the time checking for the size of the head. Concerning the eyes, many children are short-sighted. So first of all, you need to find the correct glasses and macular degeneration. This can be very difficult for children because sometimes the children are not able to see. To sum up, CNMs are multi-system diseases and they are affecting many parts of the body. But what we need to monitor is mainly the size of the body, so the macrocephaly. We also have to occasionally check the liver and the pressure of the blood and the blood gases. We do a regular sonography of the stomach. And although there are no signs that there is something wrong with the heart of children, we still do regular checks in order to completely eliminate any risks. And X-ray of the skeleton is also a difficult question because I wouldn't personally send my children to X-ray all the time. That's it for me. Thank you very much.
Okay, vielen Dank. Hier eine Frage ganz hinten.
Thank you very much. There's a question over there. You said we should give our children vitamin D. Is 1,000 units per day enough, or would you say more? Oh, okay. Otherwise, it will be too much, simply. Can you answer that? Otherwise, it will be just too much, you know. So the maximum dose would be? No, actually, I would give them 1,000 units. I mean, if the level is rather lower, then you could give more, but basically we give the usual prophylaxis dose, and that on average is enough. Just a brief question. Have you got any other recommendations what we could do or how we could positively influence the bone? I heard that in the States they are more active in that respect, and sometimes I think we might be able to do more than just giving them vitamin D. What other supportive possibilities are there? I think one part you'll hear today with Galileo or other physical medical measures, you can do something that depends on the availability, of course, and that depends on how the child can tolerate it, and also whether you've got scoliosis that can cause problems in that. So that's one thing. In case of biphosphonates, that's the medication which is usually used in case of osteoporosis when you have adult patients. I would rather be cautious because I'm not really convinced that a heavy bone must be a good bone all the time. Because, you know, bone degradation is also necessary in order to get good strength. I mean, you won't just build a bridge today by putting 10 tons of cement somewhere. You first have someone who knows about statics and who knows where the cement should be placed. And exactly the bone, the osteoblasts have a possibility to really rebuild the bone. And when we take that out, I don't know whether it's really good all the time. If there's a fracture in children, that's a different matter. But then, at least, sometimes with our jaw surgeons, we have discussions at what time you should start taking it, because we know, also in case of adults more than in children, this can cause problems. And if you plan any surgery in the future or such things, then it can also lead to some difficulties. So I personally think that there is enough data to prove that you can use biphosphonates as a prophylaxis. I don't know how you do it in the UK. Maybe you can say more about that. You talked about biphosphonates. We are using them on a regularly basis in Duchenne, but not in case of myotubular myopathy, at least not now. There's a question there.
Just one comment too from the North American perspective, which is that we haven't routinely been using bisphosphonates either for MTM, and it'd be interesting to know overall what the incidence of pathologic fracture is, because that's often been the indication for trying to use it, as you mentioned. So it's not a frequently reported problem, so I can see why it hasn't been used as much. My question is related to screening ultrasounds, abdominal ultrasounds. I know at one point that was actually part of the recommendations, and Gail Herman in the US was doing it quite frequently. And in talking with her, she didn't really find anything. And so my question is whether there really is any, have you found anything by doing screening ultrasounds? And if not, is it best to just go symptomatically in terms of abdominal complications?
Ist das auf Deutsch übersetzt worden, die Frage?
Ja.
Von Tim? Ja. Bitte auf Deutsch antworten.
Okay. Also
we do the ultrasound, and we also know that the findings that were reported had all been found in children who had full piliosis. And even then we couldn't always see something, apart from having some blood in the liquid in the cavity, in the abdominal cavity. Now, it's really a question whether you could really detect this phenomenon by ultrasonic examinations at an early time. But still, I think we still do it, you know. Just a small comment. I think I share your view here. Our pediatric hepatologists have looked at some children with myotubular myopathy and did some liver ultrasound, and indeed they couldn't find much. So obviously, it seems as if the piliosis is more of a catastrophic event, which is developing all of a sudden, but not in small degrees. Okay, thank you very, very much for